Okay, guys, we are ready to hear from Dr. Leo Lustgarten, and he is, he's actually somebody the In Brain Cancer Initiative team knows pretty well, but he is going to join us now and provide a presentation about the Optune device. And he is, just so you know, he has practiced in neurosurgery for 25 years. And he now serves as a medical director for Novocure. So he's a neurosurgeon, radiosurgeon, and he is going to be joining us today. Dr. Lustgarten, are you there?
Yes. Hi, Dylan. Can you hear me?
Yes.
I am indeed.
Great to see you.
No, it's a pleasure seeing you again. Mm-hmm. So I'm ready when you are.
Okay. Give us a minute.
Yes, of course.
You should be all set to share your screen.
Okay. So can you hear me okay? That's the first question. Yes. And second, please let me know if you can see my slides in presentation mode.
They're fantastic.
Perfect. So I'll start. I don't want to delay anything in your schedule. So first thing first, Dylan, Susan, Sean, and team, good morning and good afternoon, not only to you, to everyone who's an audience in this fantastic meeting. I wanted to thank you and the End Brain Cancer for the invitation and also for allowing us to share a few minutes to talk about Tumor Treating Fields. Again, it is both a privilege and an honor to be here and sharing all this information with you. So I shall probably start by saying that this idea came from the brilliant mind of Professor Yoram Palti. He's a physiologist and biophysicist from the Technion Institute in Israel. And as you will see in the following slides, I know some people in the call have been already exposed to Tumor Treating Fields or know about it, but some of you have not heard of it. So I'll go a little bit to basics. But anyhow, this is something that was unheard of at the time when he came up with this invention and this innovative concept. Needless to say, and you know that comes along whenever you have a bright idea or an out-of-the-box idea, those ideas always come with criticism, skepticism, and probably, most at the time, I can say that most scientists and colleagues told him he was crazy and he would fail. Well, he actually proved them all wrong. So to give you a perspective, this came at a time where the only treatment alternatives that we had for glioblastomas were actually surgery, radiotherapy, or drugs. And when I mean drugs, I mean chemotherapy. At the time, basically, there were no targeted therapies, monoclonal antibodies. So there were very rudimentary types of chemotherapy. This was even before temozolomide came along and was actually approved by the FDA. So this was kind of a very innovative idea at the time. I myself can tell you I was fascinated with this idea when I first read about it in a journal, in Neurosurgery article in 2012 or 2013, and I thought this was going to be revolutionary. I actually never thought I was going to end up working in a company. So let's dive a little bit into what it is. So for those of you who've never heard of it, tumor treating fields are basically low intensity, intermediate frequency, alternating electric fields that essentially what they do, they interfere with biological processes inside the cells. So if you imagine all of our cells are full of electrically charged particles, proteins, organelles. So delivering electrical fields makes perfect sense that you will create some sort of distress on these cells. And the first mechanism of action that was actually studied, and I would say that it's the mostly well-known, is the mitotic effect. So meaning mitosis is basically the way the cells replicate. So cancer cells, by default, they replicate very rapidly. So the way this device is set up and the settings only interfere with these cancer cells, and they do not interfere with normal healthy tissue. That is very important. The other important thing is that this is a local regional therapy, so it is only applied where the tumor is. In this case, is the scalp in the head. And just to give you a little bit of perspective, it has been approved by the FDA in 2011 for recurrent glioblastomas, and then in 2015 for newly diagnosed glioblastomas. And we also have another indication, which is malignant pleural mesothelioma. This was what we call a humanitarian device exemption approval by the FDA. So you can see here that it's not only working for glioblastomas, but it's also working, and we have shown that in different preclinical research that it also works for different cell lines. So electric fields is not really electricity, and that might be a little bit confusing, even though most people use it interchangeably. But as you can see here in the graph, we have three different types of fields, and I would like you to see this particular graphic because it's very nice. We have gravitational fields, so you know gravity, it's there. We don't see it, it's invisible, but we know it actually exerts forces on masses, and that's why they actually fall, and we have the typical example of the apple. Then we also have the magnetic fields, which again, they exert forces on iron and other magnets. And then we have electric fields, which essentially are fields of force, and what they do is they drive electrically charged particles from one place to the other. And that's what electrical fields are. And they are also different than other types of therapy. So as you can see here with the drugs usually you have to take a drug and then it will reach a peak in your blood levels, and then it starts decreasing, and before it actually comes back to the normal, you have to take it over again and again in a certain frequency in order to maintain levels, therapeutic levels. With radiotherapy, as you know, we have to apply radiotherapy daily. And again, radiotherapy affects both healthy and non-healthy tissue, but we are allowing, the reason for applying this every day for several weeks is to allow the healthy cells to recover from the damage. But then you have tumor treating fields that has no half-life, so it's not a drug, and you don't apply it like radiotherapy, like once a day in a dose. Tumor treating fields basically works as long as the device is on. So it's kind of a turn on, turn off, like a radio. You turn on the radio, and then once you don't want to hear radio anymore, you turn it off. It's very similar to that. So the device and the treatment, the tumor treating fields are only working as long as the device is on. For those of you, you might be wondering, well, electrical fields in medicine. Well, it has been in the market for many years in different types of medical devices. As you can see here in this graph, cardiac pacemakers, they work with electrical fields. There is a huge difference into what you can see here in the graph. So we have what we call the low frequency medical devices, such as a heart cardiac pacemaker. And what makes the difference is that they actually work at a frequency where they can excite muscle and nerves, but they don't affect anything else. And that's why they work so perfectly well at that setting. And on the other spectrum, you have the very high frequency devices, such as the ablation devices, and they create a lot of heat. So tumor treating fields, the settings, the fact that they are low intensity, intermediate frequency, they have been tested, and they are finely tuned to only affect unhealthy tissue or cancer cells, but they do not affect normal healthy tissue. And the other thing is that they are high enough not to excite muscle or nerves, but low enough in frequency in order to avoid heat. So it's kind of the perfect setting to affect glial cells. The other important thing that I wanted to mention about tumor treating fields is that we have, for years, we have spoken about the anti-mitotic effect. So remember what tumor treating fields does essentially is that once you start applying these alternating electrical fields via two pairs of arrays, so they work in pairs, and what they do is they basically, once you have the device on, the electrical field alternates from one array to the other, and this happens at 200,000 times per second. That's what 200 kilohertz means. And what they do is that the way they work, they align certain electrically charged particles in the same field of the electrical field. And in that way, they disrupt mitosis. So the cells that are dividing, they arrest the division, or they stop it, and then the cells end up dying. And that's the way it works as an anti-mitotic effect. The fact of having two pairs of arrays is that because we don't know spatially and three-dimensionally the way the cells will be dividing in which position, in this way, by applying two different electrical fields on the same patient with two pairs of arrays, we're trying to capture as many dividing cells as possible in order to be more effective. But we've known that for many, many years. But as the more we research, the more we know about it. And we now have discovered so many other mechanisms of action that we know are in place. Like, for example, that we already know as well that tumor treating fields alters and damages the DNA, but not also it damages the DNA, it damages the way the DNA is repaired. And this is why we are combining tumor treating fields with radiotherapy in our clinical trials, because we think that that combination is synergistic. Again, this is ongoing investigation, but we also know that tumor treating fields affects the cell membrane permeability. It makes it more permeable. It also affects a process called autophagy. It somehow hinders the capacity of the cells to migrate or to invade. And also, it has an effect on the immune system of the microenvironment in the tumor itself. So it enhances an immune response, which we can potentially use with immune checkpoint inhibitors or certain drugs in order to be more effective in terms of treatment. So as you can see, if I had done this presentation maybe 10 years ago, I would have probably talked about only the anti-mitotic effect, so the effect on the replication of the cells. But now, as the years go by, we already know that there are more and more mechanisms of action. And not only that, I'm probably sure that if Dylan and team invite me in 3 years' time, we will probably have 5 more mechanisms of action that we're actually discovering almost every day. And this is fascinating. And again, as I told you, if you think about this, if you think about the cells being electrically charged particles, they have molecules, proteins, organelles. Anything that delivers or applies any electrical field on them will cause some sort of distress. So this is just a nice illustration as to the whole device. It might seem overwhelming, but again, the patient doesn't have to carry all of that. And I'm happy I can see Patty here and other patients, and Tori, their tumor treating fields users. So you can see that in this illustration, you can see how the device is usually carried by the patient. And again, this is what a normal patient looks like wearing the device. So the arrays are applied in the scalp, the head needs to be shaved, and the patient can actually carry on with a rather normal life. I wanted to stress a point before ending my presentation that by being local regional, this is an extremely important point. By being local regional, it means that the arrays are placed very specifically where the tumor is, meaning that we can somehow modify the position of the arrays depending on where the tumor is. So if the glioblastoma is actually more frontally located, you will see that the arrays will be shifted a little bit towards the front or towards the back if it were an occipital one. And this is given by the MRI. So the MRIs of the patients are introduced into a special software that we use that will somehow come out with an individual array for every patient. Even though there is a default array, most patients get, I would say the vast majority, an individualized array layout for them. And the other important thing before I forget, being local regional, is that we have not seen any systemic adverse events from tumor treating fields. The only adverse events related with the device is, as you can probably imagine, is skin adverse events. So I would say that between 45 to 50% of patients will develop some sort of grade 1 or grade 2 dermatitis. Again, usually very easy to manage, or at least it's manageable. Very rarely we see grade 3 and grade 4s. And again, if a patient is obviously having some skin issues, that can be arranged, it can be treated, and the arrays can also be modified in order to avoid either hardware placed in the patient when the craniotomy was replaced, or trying to avoid obviously wounds from the scan incision. But the other important thing is, when I mentioned that it doesn't cause any systemic adverse events, this means that, as you well know, some of our chemotherapeutic drugs are extremely toxic. They create a lot of adverse events, systemic adverse events. So with Tumor Treating Fields, you can, even if you have severe toxicity from the medication, you can still use Tumor Treating Fields because it does not affect your blood levels. And this is especially important for those patients where, unfortunately, we wipe out their bone marrows with toxicity. These patients can still keep using Tumor Treating Fields. I think this is the last slide of the presentation, so I'll pause here and I'll take any questions. I hope I kept my time perfectly on time.
You did great. Thank you, Dr. Lustgarten. I would love to open it up. There are actually several patients today joining us that are using the Optune device and the TT Fields delivery system. They don't often get an opportunity to talk directly to you, so I'm gonna be quiet and let them have a chat with you, and then I actually have a question for you.
Absolutely. Do I keep my presentation, or do you want me to keep it just in case someone has a question from any of the slides?
Absolutely.
Okay.
Yeah, you bet.
Perfect.
Okay, actually, I'm going to move your presentation because you know what? I would like the person who is going to ask you a question for you to see them.
Perfect. Yeah, I agree. Thank you. So I stopped sharing.
Okay, thank you. Does anyone go ahead.
Jen has a question, of course. Hi, doctor. Thank you for being here. And the Optune has been something I've been wearing since November of 2020. And I believe that's what's extended my life. The question I have is, I'm aware every month I download data for indicating the usage time as a patient, how long I've been wearing the Optune for that month. I'm curious if Novocure is looking at data for the amount of cancer cells that were impacted while the patient is using the Optune.
Wow. Again, that's a fantastic question. And you actually reminded me of something really important that you just mentioned. So we know that using Tumor Treating Fields at least 12 hours, we already know, due to our research, that we already have an overall survival benefit. But we know that and this is the reason why we encourage our patients to wear it not 12 hours, 18 hours per day, because that is an independent prognostic factor, meaning that if you reach those 18 hours, your overall survival benefit will improve significantly. And it only gets more and more the more you use it. So meaning the more hours you use it above 18, the more the survival benefit. And that's something that we have in our data. And the fact that you're probably that we actually track the Optune usage is basically that, because we're interested in knowing if a patient is not reaching out that goal. We obviously need to know what's going on. Maybe some issues need to be addressed, and that's the reason why the usage is so important to us. Regarding to your question, wow, I would say it is almost impossible to know how many cells are actually impacted. I mean, as you know, tumors are consisting of millions of cells. I can tell you from molecular biology, and this is something that one of my bosses during my training taught me. So we know we have 10 to the 11 cells in a tumor. So imagine a glioblastoma measures 4 to 5 centimeters in average when they're diagnosed. They actually weigh about 100 grams. Again, this is kind of a rough estimate. We know that the cells are in the 10 to the 11 magnitude. With surgery, and being extremely radical with surgery, we get that 10 to the 11 to 10 to the 9. So meaning we do what we call a logarithmic murdering of cells. That's kind of a term.
Yes.
But you can tell by that.
I say eradicate, not murder.
Exactly.
Cells.
Sure.
So I have to push that on my husband. He thinks I'm making that up. So I appreciate you saying murder. I will tell him.
Yeah, no, but you're right. It should be ready. But what I'm trying to say is that even if we do the most radical surgery, unfortunately, we know we're leaving disease behind. We know that we're leaving cells, millions of cells. And that's the reason why after surgery, after being very aggressive with surgery, we still need to hit those cells with radiotherapy, chemotherapy, tumor treating fields, and whatever is available there. And as you can see, and if we actually thought about the timeline of treatments, unfortunately, we've moved very slowly in treatments. In the 1970s, we only had lomustine and carmustine. When I trained in the late 1990s, temozolomide was there, but it was not approved for glioblastomas. It was approved only for oligodendrogliomas and anaplastic astrocytomas. It was only approved in 2005. And again, we have very limited options, not because we're not doing research. This is just a very difficult enemy, but this is what we're here for.
If anyone doesn't mind, can I ask a follow-up question? I call my Optune the newborn because you can't leave home without it and you have to carry it everywhere you go. Do you see advances in making it, the rumor on the streets for us Novocure users, Optune, is that it's going to be the size of a cell phone. Do you see any progress in making the machine smaller?
Yes, well, yes. I can tell you there are very brilliant minds behind innovation. So what I learned from the company, and again, I'm a clinician and I've worked in the OR all of my life, but what I learned from this company, first of all, patient forward is their motto and they take it seriously. And we're only talking about science here, but there is a department working on many things. Again, as you say, bringing the generator. Well, we brought back the generator in the first clinical trials were kind of a VHS machine. I'm not sure if you are old enough to remember Betamax. Well, now they're only 1 kilogram, 1.2. The arrays have been, modified. So yes, we're moving forward to new innovations, both in coming with the generator, which is lighter and smaller, and with different arrays. Even, we're obviously thinking of implantable arrays at some point, but it's not an easy concept. So again, these are all concepts and ideas, and unfortunately, bringing an idea such as this to a clinical practice might take another 10 years or 15 years, but hopefully we're moving forward with that.
Thank you, Dr.
I'm just very grateful for the machine.
Thank you so much. Thanks, Jen, for those good questions. So I wanted to be sure everyone knew if they can see it in the chat section or not. If you have questions that you want to ask a physician who works for Novocure, you can email them at pinfo@novocure.com. There's been some really good questions that are actually directed to you, Dr. Lustgarten, that have happened on our chat, but we are out of time. I'm so sorry. But I know that there's a lot of comments that people would like to talk to Novocure about. So again, it's P as in physician, pinfo@novocure.com. Thank you so much, Dr. Lustgarten.
Dylan, thank you so much for the opportunity. And again, it was a pleasure being surrounded by all of these colleagues and patients. And again, we're here to support you anytime.
Thank you so much. Very important. And, I just wanted to say too, if people don't know, the Optune device is the very, very first device that was FDA approved for basically GBM. And so when we start thinking about that, Novocure opened the door to really for technology for brain cancer to be used to treat brain cancer. And there's several devices that are actually up and coming as well. And I think Novocure, you inspired them to do that. Thank you.
No, thank you.